Kia ora, my name is Alan Robinson. I will be doing my Osce 1 video today. I will note before I get started that some of the equipment I am working with is missing parts or functions slightly differently from some of that demonstrated in the AUT videos. So bear with me when things are different with the machinery, etc. that I'm using. I'm going to start with the monitor. Here we have a LifePack 12. So I'm going to start by going through the pockets on the outside. On this side we have the 12 leads and a pair of clothing shears for cutting clothing off. In the next level end of the pocket we have the pads hooked up to the lead to the machine down here, and spare pads. There is also a shock box which we will pull out and use shortly. There is on the top shelf here the 3 lead, what is actually a 4 lead, and we'll be having a look at that a bit more later. And down the bottom we have the SPO2 lead. In the back lid pocket we have the medications, so there is glycerin trinitrate, Disprin, and there is also a razor for shaving chests to get the main pads on. And we also have the capnography tube which connects up to the top port on the side here. And lastly a set of paper, replacement paper. With the paper we have the printer down here. We can just pull that open, pull out the paper that's in there and replace it. Just make sure that's sticking out. Finally, in the very back pocket we have the non-invasive blood pressure cuff and some spare electrodes for the 4 lead. Underneath that pocket are the batteries, and on the batteries we have the buttons here where we can do a battery check. So this is showing 4 lights, same with that one, so the batteries are both fully charged. Alright, so now we're going to turn it on and test some of the features. So I'm going to push on, that will turn it on. It will automatically go into AED mode. We're going to go out of that, so I push advisory, go into manual mode with the selector and push the selector to turn that on, and then we're going to go into options for the user test first, as this is one of the daily tests you do on a unit. It will self-check everything within the unit and then it will print out at the end that the user passed. So the user test has been done and it has printed out a little thing that says user test passed, so we keep that showing that our user test is passed. Alright, so now we're going to look at setting a charge and shocking. So we start by, in manual mode, going into energy select. I'm going to dial that down to a much lower number. I'm going to go down to the bottom here, 30 joules. Then I'm going to set it to charge. It will charge up, it will start telling me to shock, at which point I will push the shock button and it will discharge the shock into the test load, testing that energy delivery. And so it has shocked nicely. So the next thing I'm going to do is once again select an energy in manual mode. It's still at 30. I'm going to leave it at that. I'm going to charge it, and what I'm going to do this time is dump the load, because if somebody doesn't need that shock, we don't want to deliver it. So I'm just going to push the selector button and that will disarm the charge and dump it. Last thing with this I'm going to do at this point is hit analyze, because that will take us back into the AED mode. So first of all I'm going to put on the right arm lead, that is right hand side, so I'm going to put it on his upper chest up here, and there is the right arm. Left arm onto the upper left chest, near his arm. Then I have the right leg, which I'm going to put on his lower abdomen on his right hand side, and left leg, which I'm going to put on his lower left abdomen. And we have a nice little rhythm here. Well done, Molly, you have a good rhythm. Alright, so we have a nice waveform here from Ollie's heart, we're going to have a look at different lead views. So we can push the button lead, and this will bring up a selection we can choose from here. So we're going to come down and do 2, 3 and AVF. Select that, and that will display that one. Size, by pushing the size button, which brings up a chart here. We're normally at 1, but we can increase that as well. And you'll see that the size of the waveform has increased. Changing that back down to 1. We can also have an audible heart rate here. If we use the selector to swap through the various sections up to the heart rate and select that, then we have QRS volume, select that, and we have a audible representation of Ollie's heartbeat. Alright, turn that back to 0, and home screen to go back to the original view. Alright, we can also print off a strip. So on this side we have 12 lead, transmit, code summary and print. If I hit the print button, then it will begin to print off a rhythm strip for Ollie. And once I've got enough, then I just hit print again to stop. And there we have a rhythm strip that we can deliver to the hospital with our EPRF. Thank you all. Thing from the life pack here is the SPO2. It just slides onto the finger like this. Do be aware of any cold limbs or fingernail polish. Once it's on, we should get a waveform here for the SPO2. If it is a nice waveform, that's an indication that it's measuring well. Significance of the SPO2, if it is below 94, that's going to be an indication the person is not perfusing oxygen well, and we may need to put them on oxygen supplemental. The next piece of equipment I'm looking at is our oxygen. So first of all, identifying the oxygen cylinder, we have a label which says medical oxygen, and also they should be all white bottles. We have a regulator on top, which at the moment is attached. I'm going to make sure that that is closed and bled of oxygen first before I remove it. Just undoing the thumb screw, you can remove the regulator. In here we have the Bodox seal, which seals it against the cylinder. Make sure that you don't touch that, don't get any oil on it. 2 locating pins that fit into the locating pins on the side so that we can accurately get it in the right place. Once you have the Bodox seal up against the side of the valve, then tighten up the thumb screw 1/4 of a turn or so, and make sure that your gauge is pointing away from you when you turn it on, just in case it's loose. So we can turn that on. That tells us how much oxygen is in it, and on the end here we have the regulator to regulate the flow rates. Flow rates, depending on the equipment you are using. For nasal prongs, we run it at 2 to 4 litres per minute. For an acute mask, we will run it at 6 to 8 litres a minute. If we're using a nebulizer, we would run it at 8 litres a minute, although most often now we will use medical air for nebulizers rather than oxygen. A high concentration mask we will run at 10 litres a minute, and if we're attaching it to the bag valve mask, 10 to 15 litres per minute. On the side here we have the masks as available. So there is the nasal prongs, the acute mask, the high concentration mask. So this is the one I'm going to open up. We have the mask itself, which fits over the patient's face, and attached to that is the oxygen tubing, which will be straightened out and then attached to the spigot on the end of the regulator. I would dial that up to 10 litres a minute. What we want to be doing as we run this is making sure that the reservoir bag is filling up, and that as the person breathes, the reservoir bag is not completely deflating. We want to make sure that the flow is adequate to keep that reservoir bag full, so that as they breathe, there is plenty more oxygen in there for them to use. Indications for using oxygen: anytime we have an SPO2 of less than 94% for a reasonably healthy casualty. If they are CPOD, that tolerance goes down to 88. If a casualty is sedated, if we have carbon dioxide and carbon monoxide poisoning, if it is a diving emergency decompression, for casualties in shock, if they have a traumatic brain injury, respiratory distress, airway obstruction, or if they have suffered smoke inhalation during the fire. The next piece of equipment to look at is the suction. So the suction, indications for suction: if somebody's GCS is decreased or they are immobilized and they are vomiting, then we may need to clear the airway with suction. If it's a large volume, then we probably want to roll them first and get the most of it out. When we get the suction on our shift, we should test it. So normally it's sitting on the wall in the ambulance and you'll be able to see the charge lights. What I'm going to do here is I'm going to turn it on to full power. It does a battery test and then it starts suctioning. On the handle, the anchor handle, we put a thumb over the hole and cover the end and see that it is sucking appropriately. And that looks good. So then I'm going to release that. When we are suctioning, we're going to turn it on to full power. We will only insert the anchor handle as far as we can see into the oropharynx, down into the airway. We put it in as far as we can see, cover the hole on the handle, and that's when it will start suction. With a circular motion, we suction on the way out, not on the way in, and only for about 10 seconds. If we have a child casualty, or if we're in a moving vehicle, or if we need to clear the nasal passages or an ET tube, then we may use a soft catheter. The soft catheter fits on the end. With this equipment there is no soft catheter, so I'm just going to use a capnography tube to demonstrate a little bit. We would again measure, same thing, that we are not going to go past what we can see. We can wrap a little bit around our hands so that we have that measure and can't go beyond that. It will attach onto the anchor handle and we can still use the same hole on the handle to activate the suction. Going in, activating, circular motion, suctioning on the way out, then release. As it suctions, anything that it picks up will go into the reservoir here. We do not want to let this overfill, and if it's getting very full, then we probably should have rolled the casualty, because that's far too much for the unit to handle. Complications, so sticking this to their airway, if they do still have gag reflex, etc., then it may induce vomiting. It could stimulate the vagal nerve and cause bradycardia. It could reduce the oxygen intake as it sucks the air out of the casualty as well, so they may end up going with hypoxia. Could cause aspiration where they inhale the fluids down into their lungs, causing a laryngospasm. If you go, this is why you should only go as far as you can see. If you go too far, you might hit the vocal cords and cause a laryngospasm. And if you're not cautious about how you use it, you could also cause soft tissue trauma in the mouth. If you get stuck to the side and suction, some of the tissues will poke them around. The first response pack, we have a number of pockets on the outside. On one side we have one large pocket which contains all the hemorrhage control equipment. We have some bandages, some dressings, some omni strips, two tourniquets, some saline for washing, and some triangular bandages for washing or wetting dressings. On the opposite side of the pack we have two pockets. One is for sugar, glucose. There's a pack of glucose IV and a glucagon pack. Checking the dates on these things and checking for clarity, making sure that they are usable. In the upper pocket on the side we have some PPE, there is a pair of goggles, some emesis bags, a lanyard for cervical spine, and a cold spray for numbing areas on the surface of the skin. On the front of the pack we have two pockets. The upper one contains most of our diagnostic stuff, so there is an adult blood pressure cuff, a child pediatric blood pressure cuff, and a stethoscope to go with them. There is also a pair of shears, a thermometer and pupil torch, and a blood glucose level meter. The lower pocket on this one has some blueies for putting underneath the patient, and some more PPE, a pair of face masks. Right, so that's all the outside pockets. As we get to the inside pockets, we're going to be looking at more of the airway management and drugs and stuff. So if I open this up, looking in the lid first, the very top pocket has some drugs in it. We have in a little packet here some paracetamol, ibuprofen, tramadol, and also some antihistamines. And also in this top pocket, this one is all tied together, is methoxyflurane. Next pocket down, we have a biohazard bag, a small pack with a laryngoscope and lubricant. We also have the McGill's forceps, so we can use that with a laryngoscope to remove foreign body objects from the airway. On this side we have some nasopharyngeal airways, which we will need some lubricant to insert. And on the opposite side we have some oropharyngeal airways. The next pocket down is for airway asthma, and in here we have a nebulizer mask, which we will probably use medical oxygen for rather than medical air rather than oxygen. And in the pack here we have some drugs for when people are suffering asthma. We have ipratropium and salbutamol vials, which we will put into the nebulizer. There is also adrenaline injection, and in this one we also have some prednisone, the steroid. Moving on to the main body of the pack, I'll just carry on in the same direction. We have a sharps container, two giving sets, a saline bag, again checking dates and clarity, etc., to make sure it's good to use, and a slippery Sam. The next pouch up is the adult bag valve mask, and I'll be demonstrating this a bit more shortly. Then a pediatric bag valve mask. At the top end we have some IV materials for the paramedics and ICPs, and underneath that there is a bag with LMAs, Thomas holders, a syringe for the air going into the LMAs, and some lubricant. Down the side in the main pack here we have a collar, a stiff neck collar, and some cardboard splints for fracture management. First, when is airway management appropriate? Whenever the GCS is lowered and the person is unable to maintain their own airway for any reason, then we can assist by doing some airway management things. The first thing we can do is some positioning. So tilting the head back, head tilt, will pull the jaw up and help to move the tongue off the back, and we can do a head tilt and chin lift where we grab the jaw and lift it up as well. The other way we can move the jaw if head tilt is inappropriate because there may be a spinal injury, we can instead do the jaw thrust, where we put the pads of our thumbs on the cheekbones and put our fingers behind the angle of the jaw and thrust the jaw up by closing our hands. This should again move the tongue off the back of the airway. Things I'm going to show here are the oropharyngeal airway and the nasopharyngeal airway. The oropharyngeal airway is appropriate whenever the GCS is lower than 8, the motor score is less than 6, or they have incomprehensible sounds to pain. Be aware of the gag reflex. If we insert this and they are still gagging, then they may gag on it and try to spit it out. Trismus, locked jaw, we may not be able to get it in, and if they're vomiting, then it may be inappropriate as it will reduce the ability of the person to get rid of their vomit. We need to size it appropriate for the person. To size it, I've already pre-sized, got the right size here, pre-sized, but we're going from the corner of the mouth down to the lobe of the ear. When we insert, cross finger technique to open up the mouth, look inside, we're going to insert it upside down with a curve to the roof of the mouth until it meets resistance and doesn't drop any further on its own. Then rotate and drop it down behind the tongue. It can just sit on top of the lips there, and this will help hold the tongue out of the way to keep that airway open, even though we may not be doing a head tilt or a jaw thrust at the same time. We additionally have nasopharyngeal airways for whenever an OPA is inappropriate due to facial injuries, trismus, they have an intact gag reflex and we're unable to use the OPA. Again, for a GCS less than 8, do be cautious around head injuries because if there's a skull fracture we may accidentally impact upon that. We're going to pick an appropriate size and similar to the OPA. This time we're going to measure from the nostril down to the corner of the jaw, and we're going to lubricate it with a water-based gel and insert it straight down to the nostril, picking the biggest nostril or the one that seems to be the most appropriate at the time. We're going to insert it, just slide it down. If you've got a good size, it should just sit on the edge of the nostril like so. Other positioning things we may use is for a small child or infant, we could put their head into the sniffing position. So instead of tilting it all the way back, which may put pressure on the airway of a small child that has not grown the cartilage and therefore is not rigid yet, we can instead go to what's called the sniffing position or neutral position. So tipping the head back, but not into the full head tilt right back. Another position we can use if the patient is vomiting large amounts or we need to leave them to attend to somebody else, we can put them in the recovery position. Transporting in the recovery position is indicated as well. So for a recovery position, we turn the person onto their side so that their tongue and the airway will fall forward and open up, and any vomit will drain away if they vomit while they're semi-conscious or unconscious. When we open this up, there's a number of pieces that go together to form the bag mask, and the assembly is required. So the first thing I'm going to pull out is the bag itself. It is usually in a collapsed state. We can open that up. At this end is the valve. It's a one-way valve so that when we push air into the person, it will come back, return and blow out through the valve around here. At the other end we have an oxygen port and a port for the reservoir bag, which the oxygen will fill up and that will be then available for blowing into the person. We may use a PEEP valve. Now the PEEP valve has an action of splinting open the alveoli with pressure so that as they exhale the pressure is higher than atmospheric and manages to and keeps the area, the alveoli open. It is measured in centimetres of water. So there's just a knob here that we wind up to the appropriate thing, and that increases the pressure on expiration, positive end expiratory pressure. This is not indicated for use during a cardiac arrest or with pneumothorax, but may be used also with conscious patients or semi-conscious to splint open their airways during transport. The next thing I'm going to pull out of the bag is the valve filter. This is just to filter any returning air, keeping it from getting clogged up. and lastly the mask. So this completes the assembly of the bag valve mask itself. I'll demonstrate that in a moment. We also in here have some other size masks and some oxygen tubing. So the oxygen tubing, as I've already shown, connects to the spigot, the port here on this end, and then we'll connect to the oxygen. We can then attach the oxygen tubing to the regulator on our oxygen, and again onto the spigot there, and setting the flow rate at 10 to 15 litres per minute, watching the reservoir bag to make sure that is inflating between each breath that we give them. For using the bag valve mask, we place it on the casualty's face with the wide part of the mask on the chin and the pointy bit up to the nose. There are two hand grips we can use. We can use the one-handed CE grip, a C around the mask and an E around the jaw to get an open airway, and then when we squeeze the bag, 3 fingers, 1/3 squeeze the bag, watching that chest to make sure that we are getting inflation, the chest rise and fall. The other group we can use is if we have 2 people available for using the bag mask, then we will go back to essentially that jaw thrust that I showed earlier, where we're going to place the hand on either side, fingers underneath the jaw, pulling the jaw up into the face mask. We'll get a much better seal with this, potentially, and somebody else is going to be squeezing the bag for us to inflate, to ventilate the chest of the casualty. So when are we going to use the bag valve mask? During cardiac arrest, potentially during a non-cardiac arrest if we want the PEEP valves for the splinting effect, or if the person is having a decreased respirate and we need to give intermittent breaths for them. Predictors of difficulty for getting a good seal with the mask, so facial hair, facial trauma, we can use some wet cloth to help seal against beards, etc. Obesity, when there's going to be an extra pressure on the airway because of the weight around the chin, around the neck. Obstruction with something in the airway. Age, they will lose tone of muscle, etc. No teeth, or because they've got dentures that have been removed and therefore the face will sink down and make it much harder to get a seal. Or neck mobility is the other N, so if we are unable to tilt the head back to get an open airway, then that will make it more difficult. Stiff around the jaw, making the trismus, for example, making it more difficult to get an open airway, and snores, the person has a potential blockage of the airway because of their tongue and their pharynx closing up with the snoring. When we are ventilating the casualty, we should be following the rule of threes. The rule of threes is 3 fingers on the bag to squeeze, squeezing 1/3 of the bag, and for no more than 3 seconds so that we are not pausing the compressions for too long. Rates of compressions, so we are doing during normal CPR 30 to 2 until the tube is in, and then we can do breaths during compressions, otherwise the rate is 30 compressions, 2 breaths. For pediatric, we are 15 to 2, and for neonates it is 3 to 1. If we are not in cardiac arrest and we are assisting breathing, then we want to be seeing 1 breath every 6 to 8 seconds. If we are not seeing a breath in that time, then we will assist by giving them assisted ventilations, breathing for them when they are not breathing themselves. Complications, if we are squeezing too hard, and this is why the rule of threes, if we squeeze too hard, we may overfill the lungs, and this will then force air down into the stomach and cause rigidity in the abdomen, which will reduce the effectiveness of CPR, and or potentially cause more emesis vomiting, which will then be an airway